This is Heart Rhythm TV. I'm Roderick Tung. We're excited to talk about the latest featured article in Heart Rhythm Journal. This is coming from Hyderabad, India. We have Dr. Muthiah Subramanian and Dr. Narasimhan. Welcome to Heart Rhythm TV.
Thank you, Rod. Thank you.
So what we have is this huge interest or re-interest in Bachmann bundle pacing. We just did the Physiology Pacing Symposium, and Dan Lesgard and Maggie Infeld were leading that. But clearly, you have been ahead of the curve in India. Please talk to us a little bit about why Bachmann bundle pacing has been something of intrigue and interest to your group.
Thank you, Rod. I'll just lay the context and ask Muthiah to present the findings. See, there's mixed results about Bachmann bundle pacing because of a heterogeneous subgroup. Whereas non-obstructive cardiomyopathy is the purest form of diastolic dysfunction, and they have a high prevalence of intra-atrial block. So if you don't have these substrates, if you don't have intra-atrial block, it's unlikely to show a significant benefit. So I think that is the key, is to select your patients, right? If you have significant intra-atrial block with HFpEF-like physiology, this is likely to improve. And most of the work was done by my colleague Muthiah, and he'll tell you briefly the findings.
Yeah, Muthiah, tell us how you recruited over 40.
Yeah, so I think we need to start out by understanding we have a lot of hypertrophic cardiomyopathy patients that we follow up. We have an institutional HCM clinic. So we sort of find that HCM patients are endemic to this region. And so we've been treating a lot of non-obstructive HCM patients, which often behave like a HFpEF phenotype. And some of the treatments work and some of them don't. So we started looking at a subset of these patients with interatrial block. And then that's where the idea started that we may be able to sort of improve their diastolic filling by correcting the interatrial block. And that's sort of the basis of this study. So we recruited these 46 patients actually 50 patients that we actually screened over 3 years from our institutional HCM clinic. And if these patients were symptomatic HCM patients and we had some BNP criteria that had to be met, and it was important that they had a baseline interatrial block and also had an indication to receive, at this point at least, to receive a dual chamber ICD. And then these patients underwent Bachmann bundle pacing. And if we were successful with Bachmann bundle pacing, then they were randomized to either Bachmann bundle pacing on or Bachmann bundle pacing off. So 21 on each side because we were successful in 42 patients. And then washout. So this pacing happened only for a very short time. And I think that's the very important part of the study. So this only happened for 4 weeks, washout for 4 weeks, and then crossover for 4 weeks. And on the other hand, we had a historical sort of control of 26 patients, which had similar non-obstructive HCM, had already had a dual chamber ICD with an appendage, right atrial appendage lead. And this served as a control. And these patients were also paced for 12 weeks.
Excellent. So, and for the viewers, you define interatrial block as a P wave of greater than 120 milliseconds, right? And partial could be notched as well. Is that right?
Yes. So these are standard definitions. 120 milliseconds in the inferior leads, partial or complete based on the morphology if there's a terminal negative deflection or not. But it's a standard interatrial block definition.
Excellent. And then tell us a little bit about your endpoints. Your primary outcome was really NT-proBNP, and you also looked at echocardiographic parameters.
Yes. So I think that so we wanted to keep the primary endpoint simple. So the primary endpoint was only a change in BNP compared to baseline. And the secondary endpoints had functional capacity in terms of NYJ class and 6-minute walk distance. But we really looked at the echo, looked at diastolic parameters on the echo, daily diuretic dosage, as well as atrial arrhythmias.
Tell us what you found.
So I think I think one part that I probably didn't mention was the pacing rate was very important, and I think that's probably based on the MyPace trial. So we decided that you needed a moderately accelerated atrial pacing rate. So we picked a rate of 70 beats per minute. And so patients were either paced at 70, not paced at 70, and we had a control arm where right atrial appendage pacing was done at 70 beats per minute. So you could say there were 3 groups. So I think the most interesting point was that when Bachmann pacing was on, there was a significant improvement in NT-proBNP, and all of the secondary endpoints improved. And this difference was far more significant for pacing on versus pacing off. But there was even an improvement when you compared Bachmann pacing on versus right atrial appendage pacing on. So this tells us that it's the rate makes a difference, but the site at which you pace that even makes a probably even more bigger difference in terms of achieving good endpoints.
That's very impressive that just the site of atrial pacing and the accelerated. So there are 2 variables.
Yes.
And I like that it's inspired by MyPace, but really has significant reductions in NT-proBNP, which we often think is more potentially ventricular stretch and ventricular strain, whereas ANP historically, but this has very high relevance for ventricular performance. So where do we go with this? And do you believe that there needs to be a BART 2? Do you have something else planned, or do you believe that this is the way to go for all of your patients with P waves greater than 120?
I'll take it probably. I think we need to, there are a lot of caveats here. When the left ventricle gets activated first, that is, if a person has a baseline right bundle branch block and a relatively normal PR, you'll find the LV is contracting and the LA will be contracting against a closed mitral valve. So I think there are several features which we need to tease out. I think it's important to do a multi-center trial to find out there are subsets who may not respond. Even in our group, some of them had scarring in the Bachmann area. We couldn't implant it. That's where the numbers dropped to 42 because some of them had already developed scarring. Suppose a person had a Waka of the right sided pulmonary vein, it's likely that area you may not be able to capture. I'm just guessing. So there are several things unknowns in this area, but it's important to form a registry. There'll be a subset of patients who will respond better than the others. They are the ones where there's LA contractility is far delayed, electromechanical dissociation of LA, which contracts almost, which doesn't allow optimal LV filling. As you know, this is predominantly a diastolic disease, and these patients are more likely to benefit from synchronizing the atria.
And when we look at this beautiful figure that you provide, not only do you show the NT-proBNP reduction, which is quite dramatic, the 6-minute walk, which was not your primary endpoint, but really good supportive functional information, and the diuretic requirement was significantly reduced as well. Very impressive.
And I think the important thing is actually they only received pacing on for only 4 weeks. So these results are, even though we've only paced them only for 4 weeks, I think the results are quite nice.
Narasimhan, when you have done any of the mapping in these patients, have you ever done biatrial maps to see where the sites of interatrial block are or where the conduction disease is? Is it truly in the septum always? Or is it variable?
I haven't done. Unfortunately, we have not done. We have done biatrial maps for difficult flutters, biatrial flutters to ablate, but not with this specific mind and specific question in mind.
And then also, as Bachmann is becoming in vogue again, does that change how you do your mitral lines for complex flutters? Are you abandoning anterior mitral lines?
Yes, that is quite worrying to do the anterior mitral line. It's quite likely you may completely disconnect the appendage there and can worsen the intraatrial block. So even though you can get rid of the arrhythmia, mechanical function may leave a lot to be desired if you create a long mitral line and disconnect the left atrial appendage area.
Well, I would like to congratulate your group. Narasimhan, you're always pioneering something new, and we're grateful for that. The field is grateful, and we really are delighted to feature a global initiative all the way from India. that is teaching us the potential value with this very brilliant mechanistic crossover study. Hopefully others will replicate this. And you chose a very great population, as you're saying, it's highly enriched for interatrial block conduction disease and diastolic, right, optimization that's required. So I think it's a great population you chose, and amazing you have that infrastructure with this HCM clinic. So congratulations, and thank you so much for joining us on Heart Rhythm TV.
Thank you very much. Thank you.
Thank you.